So what's the most powerful weapon that we have against COVID-19? Next slide. The answer is you, armed with a bar of soap. Because when we don't have any vaccine and we don't have any effective or specific treatments, it's the power of individual behaviours that is the most effective against this virus. Next slide. Because to prevent the virus spreading, next, we need people to do things like wash their hands, cover coughs and sneezes, clean their surroundings, limit time spent in crowded and enclosed spaces, and to find new, safer ways of living and working. Next. So first I thought I should just explain a little bit about what the Western Pacific region is, since it's something that's completely made up by WHO and exists nowhere outside of our minds. But essentially it's 37 countries and areas, ranging from Mongolia in the north to New Zealand in the south. It includes the most populous country in the world, but also some of the smallest countries, because we include Pacific Island nations. It also includes a lot of countries with varying risk communication capacity. So we have risk communication superstars like Singapore and New Zealand, but we also have countries that are slightly more autocratic in nature, countries which rely heavily on tourism and are sometimes a bit reluctant to communicate openly. Also countries that have just very little capacity in general, and so the person responsible for risk communication might be half of a person who's also taking care of several other things. Like they might also be the laboratory specialist or something else. Next. So in the WHO regional office for the Western Pacific region, what we're doing for the COVID-19 response fits into 5 main buckets of activities. So the first one is technical support. WHO is a technical agency, and the value we provide is in the expertise that we can offer. So part of what we're doing is to provide advice and support that's valid across the region. So things that are maybe useful for as many people in as many countries as possible. So that includes things like technical guidance, like publications that explain how to do certain things, but also maybe messages and materials that can be adapted. It's webinars, where tomorrow we'll be holding our 11th webinar, which are usually intended by Ministry of Health counterparts and our WHO country office risk communication specialists. And they are on topics from addressing stigma to how do you communicate large-scale transmission of the virus. The one tomorrow is communicating the new normal phase 2. But then, so that's the cross-regional work, but then also we provide targeted support to 7 priority countries. And those are mostly low and middle income countries, because that's where we feel we add the most value. And these usually also where we have a WHO physical presence of a country office, and where the response to an emergency like COVID, it's really a joint response led by the government, of course, but with a lot of support and backing from WHO. Then the next thing we're doing is conducting regional listening activities and behavioural insights. So we're pulling together social media monitoring, surveys and polls. We're pulling together whatever information that we can get and using that to inform response decision making. So that could, yes, it should be used to update our risk communication so that we're better meeting the needs of the people who are listening to us. But also it needs to inform the broader response. And I'll get into that a little bit in more detail in a few slides. The other thing we're doing is to support the countries and the country offices to conduct listening themselves and to also use these multiple sources of information that they have. Sometimes it might be very quick and dirty. Maybe they don't have capacity to have a very sophisticated tool for social media monitoring, but they do have someone who can spare 2 hours to read the comments under their own posts. And even that can give them valuable insights. So we're supporting them to do this. We're also coordinating with partners. So there are 74 partner organizations working together under the Asia Pacific Working Group for risk communication and community engagement on COVID-19. So WHO founded this and is the co-chair along OCHA and IFRC. And I was happy to see my IFRC colleague is presenting later in the week. And so we're all working together to make sure that our messaging is aligned across the different organizations, and so that we can boost each other's content. And those are primarily UN organizations and NGOs. We're also though working with social media companies like Facebook and Twitter, and we're talking to Google about how we can work together as well. Then of course, we're producing messaging and materials. As much as possible, those are in editable format, so that because what is relevant here at the regional office is not necessarily what's 100% relevant in a country or in a specific community. So, but we provide like a core foundation that countries can adapt. So we created something. We knew that a lot of people don't have access to or can't afford expensive design software. So what we've been using is just Microsoft PowerPoint. We create a template and people can easily change the text, swap out the images for something that looks more locally appropriate, but they can adapt that for themselves, but they don't have to start from scratch. And then we're using risk communication systems and tools to support community engagement. And what does that mean? So under the international health regulations, which is a global agreement signed by 196 countries and areas, countries have signed up to say that they will build certain core capacities, and one of those is risk communication. So many countries in our region have developed national plans for risk communication. They have developed SOPs, for example, and these can also be used for community engagement. So I think the Norwegian example was just interesting to me, because this is exactly what we're talking about. A country might have a standard operating procedure for how they coordinate with different government ministries to communicate during a crisis, and how do they coordinate that also down to the subnational level and back up again. So this can also be harnessed to support community engagement. Next slide, please. So that was a little bit about what we're doing in the regional office of WHO. But I wanted to share some lessons, and I say we've learned because it's not just we at WHO or me personally, but these are 5 lessons that we pulled together from a range of partners. So including my colleague at OCHA, my colleague at IFRC and UNICEF, also from colleagues from the Ministries of Health of Philippines and Vietnam, a colleague who used to work with the Korea Centers for Disease Control and Prevention. And so we're actually working on a paper right now that we're hoping to place soon, and goes into a little bit more detail and has some further lessons, but I've just distilled 5 of the key ones here. Next slide. So first of all, the whole of government needs to play a role in communicating COVID-19. And it's very clear that certain leaders are doing an excellent job at this. So anyone who hasn't seen Prime Minister Lee of Singapore's speeches to the public, I recommend that you go and watch those, because he does everything that we would want a leader to do. It's interesting. I think it was what Shane said earlier about communicating what people need to know, not what we think they need to hear, is a critical part of that. Also communicating with empathy, sharing what we know at a certain point in time, and admitting what we don't know. He does a very, very good job of that. And also communicating that we're all in this together. Similarly, Prime Minister Jacinda Ardern of New Zealand is doing an excellent job. I think we're all very aware of that. And I'm looking forward to seeing Suze Wilkins' presentation, that will go into that in a little more detail on Thursday. I also included on the slide a map from Friday, which is a case heat map. So the dark blue shaded areas are the places that are experiencing the most cases. Now, I don't know if this is a contributing factor or not, or if it's purely correlation, and perhaps it'd be interesting for a researcher to have a look into this a little bit. But it's interesting to me that countries, not all of them, but many of the countries that are shaded darker blue in colour are countries where the leaders did the opposite of what we would like them to do. So these are places where the national leader downplayed the risk initially, told the population that this was nothing to worry about, and then when it clearly became a concerning situation, reacted negatively, passed blame onto others, refused to take accountability, and yes, basically did everything we wouldn't like them to do. But it's not just national leaders. As we've said earlier, as the Norwegian example showed us, we need to be working across ministries. I'm fully aware also that there are many people who are signed into this call who would fully agree with that, because they're working in different ministries of government. And we also need to be working down to the subnational level, because it's people at the local government level even, that councillors, mayors, barangay captains, village heads, these are the people who know their local communities and can communicate best in a way that is acceptable to them, in languages that are acceptable to them, and are able to capture community feedback and pass that back up into national decision making. Next. So digital communication has reached a tipping point. On the one hand, this seems obvious, but on the other, I mean, we had social media for H1N1 and MERS in Korea in 2015, but never before have so many people had access to social media all over the globe during a global crisis of this nature. So it's no longer rich people in rich countries who are on social media. We have people on social media in Papua New Guinea. We have people on social media in informal settlements here in Manila. I just saw a statistic yesterday that said our Facebook presence in the Solomon Islands had increased by 250% in April. So the level of engagement on social media is now huge, which is both an opportunity so we can reach so many people, but it's also a massive challenge because we're having rumors, misinformation and disinformation spreading everywhere. So you'll see on the slide there's the example of a fake WHO post telling people not to eat bakery items. So we need to address these. Where we can, we bust myths. We also make sure that we try to have two-way conversations on social media. So in the photo is the WHO representative to China talking to Tutia, which is a major social media platform in China. And we're also, like I said earlier, partnering with Twitter and Facebook. So in that picture there is something that comes up when you're in the Philippines and you search for COVID-19 or you search for coronavirus or a related term. This message pops up that says, go here for trusted information on this topic. And it's linking people to the Department of Health Philippines and to WHO Philippines. Next slide, please. Again, this might seem obvious that we have to identify, involve and reach hard to reach and vulnerable and marginalized populations. But it's funny because even the best emergency responses in relation to COVID-19, some of them have come undone because they've forgotten one key community. So this is something that we have to be aware of. In each context, who are the people who are missing out? How can we involve them? How can we include them? How can we communicate with them in a way that is acceptable to them? One thing I'm proud of to have been part of pulling together is some joint guidance for the Asia Pacific region that we pulled together with UN Women, with IFRC, with OCHA, with UNICEF and some other partners on how to include marginalized and vulnerable people in risk communication and community engagement around COVID-19. Next. So we must listen as well as speak. And maybe this is also something that people in places like Australia and New Zealand and Canada are well used to doing. But in other parts of the world, it's been a struggle. And I think partly it's because we focus so heavily on proper social science, like CAP surveys and focus group discussions, which can be difficult to carry out when you don't have many resources, when you are that person in a country, in a government somewhere where you are only working part-time on risk communication. So we've been helping countries to get whatever information they have and pull that together and use that to adapt their risk communication and inform response decision making. At the same time, we are working to support countries that do want to conduct surveys and polls. So there's an example there from the Philippines, Department of Health run a rapid risk perception assessment survey that was supported by WHO and UNICEF, and we're doing regional level polls. So one thing, how we use this then is that when we go into our incident management support team meeting at the regional office, we take the key learnings from our listening data and we present that to the team. And you'll see here from a couple of weeks ago, for example, we saw a 68% surge in mentions of suicides and suicidal thoughts, which is deeply concerning. And then when we did a little bit more digging, we found that these conversations were mostly related to depression and anxiety, business closures and job losses. So on the one hand, yes, we worked with our mental health colleagues to develop messaging and materials on how do you develop positive coping skills, how do you manage to live in a time of uncertainty, etc. How do you help somebody who may be struggling? But it's not just that, it's also we needed our country officers to communicate with the relevant governments to tell them that when they're thinking about whether they should maintain what we call EMPAs, basically the restrictions, whether they, and the lockdowns, that they take this into consideration as part of their decision making. Next. Sometimes as international civil servants, we get a bit funny about religion because it's something that's like outside of us and we shouldn't get involved in, but it was very clear early on in this response that these were groups that we had to engage with, mostly because there were two massive outbreaks in the very beginning of the pandemic. One amongst the Shincheonji congregation in the Republic of Korea, and another in the wake of a Tablighi Jamaat gathering in Malaysia that led to hundreds of cases in several countries. So we knew we needed to engage with different religious communities in the various countries. So for example, in Laos, PDR, they engaged with Buddhist communities around the celebration of Pai Mai, which is the Lao New Year, and also Wesak Day. So you'll see in the photo on the slides, there is, that's the head of the Buddhist faith in Laos, speaking on TV about how people can celebrate Pai Mai safely in a different way this year. But we've also engaged with Islamic communities around Ramadan and Eid. We've engaged with Christian communities around Easter, and we will continue to do so. Next. So thank you, but thank you also to all the people I mentioned who were involved in distilling some of these lessons, and I'm looking forward to hearing your questions.
Thank you so much, Lauren. I've got some questions for you. The first one is, how do you manage the number of languages and dialects within the region?
That's a good question. It's not easy, especially when you're in a country like Papua New Guinea that has so many dialects. How we usually manage it is we produce materials in English from the regional office. They get passed down then to the country officers who adapt it into local languages. Usually maybe it might only be 1, 2 or 3 maximum kind of languages they can do in-house. And then if we wanted to get into very specific dialects, we're either working with partners who can translate, or potentially this is where local governments play a really, really big role. For example, in the Philippines, materials go out from the national level to the provinces, and the provinces translate it into the relevant languages.
Thank you. Another question, how do you keep track of, in an ongoing event such as this one, how do you keep track of old content? Because a lot of the research and the advice and the clinical situation is changing. So how do you keep the up-to-date content visible and get rid of the old content?
Yeah, so that's something we're kind of learning as we're doing. Actually, in the beginning, we were putting stuff out and they had no timestamp, and they can be continuing to be shared anywhere on the internet. And some of the advice has actually changed quite substantially. The one thing we're doing now is to include a date, so that it's very clear to people that this was relevant in May of 2020. And but if they see something from January or February, maybe it's not so relevant. That's how we want to approach it going forward. And actually, it's an approach that we were inspired by IFRC. This is how they often do their products. So we've started to adopt that too. And then we have, of course, there is stuff on our website. So we go through periodically and update that. So it's only the things that are still relevant that are on there. And we have a sharing platform that we use internally within the different offices of WHO. So whenever there is something that we realize is outdated, a quick message goes out to an associated group on WhatsApp saying we're not using this one anymore, and then that gets removed off the sharing platform.
I'm wondering if you have any thoughts about if there is, as you said, there's a simple, repeated, clear-cut message around wash your hands. How do you keep making such a simple message powerful over a long period of time?
Yeah, this is something we're trying to think about right now, because as we enter in this so-called new normal, people are going to need to maintain that, but also they might not feel the fear anymore that's driving them to take action. How we're currently approaching it is to create positive social norms around hand washing, covering coughs and sneezes, maintaining 1 meter's distance, etc. So part of this is about the hand washing challenge. So getting leaders, getting influencers to challenge each other to wash their hands on social media. But I'm also, it would be interesting to hear anybody's ideas, because this is something we're constantly talking about amongst the communication staff in WHO and our ministries of health about how we keep inspiring people to take these very simple actions when people are starting to relax and feel like the pandemic is over, which it's not, definitely not.
On that subject, you said you were looking at communicating the new normal. What are the central themes of that for you?
Yeah, so we're breaking it down into 2 phases. And the first phase is about the initial lifting of the restrictions. So we want to communicate that no, the pandemic is not over, and we still need to be protecting ourselves and each other. But phase 2 is something we're still figuring out, but it's something about creating a new, better normal rather than going back to the old normal. So how can we live, how can we work in ways that protects each other, for not just from COVID-19, but when we're doing things like hand washing and covering coughs and sneezes, we're also protecting each other from influenza, so many other viruses. So this is part of what we're trying to get at. It's also, we want to create a future where it's not a choice between economic well-being and health, because we see that investment in health is an investment in the economy, because you have healthy workers, for example, to continue working in your business, and healthy customers who can buy your products. We are also talking about how can we make sure going forward that we include some of those marginalized groups, because this is clearly underlined that there are some communities who are continuing to include those people going forward.
maybe two more questions we've got time for. One is the current political fracas involving WHO causing difficulty at the community level?
Yes and no. If you talk to somebody in the street in Manila, I'm sure they will have heard the news and they will ask us some questions. But so far, not really. Of course, we are a little concerned because it undermines trust when there are conversations going on at an international level for whatever reason. So far, it hasn't had a massive impact, but we're looking at the community level at least, but we're monitoring that very carefully.
And one final question. What is your best advice around vulnerable communities? How can you draw managers and leaders' eyes to them?
That's a good question. I think in terms of drawing leaders and managers' eyes to them, it's about showing the examples of what happens when you don't include them. I think that's the best example because it can completely undermine what was otherwise a very effective response. Yeah, I'm trying to explain it without pointing fingers, but I think, yeah, some of the most internationally renowned COVID outbreak responses were temporarily anyway brought undone by forgetting a certain community. So that's how I would advocate for that. And then in terms of how we involve them, I think we need to be talking to people who work with these communities all the time and also involving members of those communities themselves in the conversation and in the decision making.